So this is a abstract reporting on a dose escalation trial, first in human trial, in patients with relapsed refractory non-hodgkin's lymphoma, using as single agent a bispecific antibody construct targeting CD3 and CD20. The property of this antibody construct is that it is very close to a normal antibody, normal IgG format. So hence the half-life is quite extended, and during the clinical trial, the antibody was given once weekly for the first 12 weeks, and then after that, after response assessment at week 12, then the maintenance therapy for up to 36 weeks every second week. It's a classical 3+3 design, and we are now reporting on the dose escalation part in these non-Hodgkin lymphoma patients. So as like in all phase 1 trials, the primary endpoint is to determine the MTD as well as safety and tolerability. Secondary endpoints key are, of course, efficacy in terms of and the PFS, as well as a couple of PK and data. So overall, more than 80 patients have now been recruited, 86 patients have been recruited. Majority of them are aggressives, but there's also a substantial proportion of patients with follicular lymphoma, and then 3-4 patients with mantle cell lymphoma or marginal zone lymphoma, and 1 with Waldenström's. So in terms of the MTD, it has not been reached. In terms of safety, so with all immunotherapies engaging T cells, it is, you look at cytokine release syndrome, you look at neurotoxicity, looking at heme tox, and the rate of infectious complications. So initially, it was given without any step-up dosing, the drug, and then once we saw a safety signal in terms of patients having in the lower doses cytokine release syndrome, then a more adaptive design was then made by actually now having first week coming in with a low dose, then a second week if a medium dose, and the third week reaching the target dose defined by the protocol. And so when you compare notes, so how high was the CRS rate in the patients with flat dosing versus now this more adaptive design, the rate of cytokine release syndrome and severity seem to be less for the patients who are getting more of this adaptive design. Particularly when you think about also that we are now at 300 milligrams per patient, starting all the way out before about 3 logs lower than that. And the timing of the cytokine release syndrome is usually in the first 2 weeks, and then it dies off the 3rd or 4th week. Neurotoxicity was only seen very rarely, severe neurotoxicity only in 2-3 patients out of the more than 80 patients, so it's not really a safety issue. And also hemotoxicity, majority of patients don't show severe heme tox. There are occasional patients who may have neutropenias, but that can be then salvaged by giving them growth factors. And the 4th bucket of safety is infectious complications. About half of the patients have ID problems, mild to severe in a situation. And the last aspect, and that is due to the nature of the disease, that sometimes patients actually had perforation, for example, gastric perforation due to lymphoma involvement, and then the lymphoma then started shrinking, leading into the gastric perforation. So now in regard to the PK, as expected, there was a dose relation to the plasma concentration. And once we reached 5 mg, we were getting dose concentrations in the blood, at least peak levels, which were enough to kill off the lymphoma in Ruggian models. Once we approach levels above 20 mg, we also, the trough levels were above the levels that actually meant tumor control in mice. So responses were seen for follicular lymphomas very early onwards, and from the dose of 5 mg and higher, there's a 98% response rate with really considerable duration of response in these patients. Some patients out more than a year and a half now. So obviously these are very small numbers. Also for marginal zone lymphomas and mantle cell lymphomas, there seems to be also very clearly, once you crossed 5 mg, there seems to be a very clear efficacy signal. Majority of those patients also have a complete response measured by Jessen criteria. Looking at the aggressives, there the dose relation to response is shifted towards higher dose. There were occasionally responses seen at a lower dose where you had a response with follicular lymphomas, so at 5, 8, there was some efficacy already happening there. But once you cross the line beyond 80 milligrams per patient per infusion, you'll be getting robust signals with your now like 6-7 patients. Obviously, duration of response is very difficult now to talk about that because these responses occurred just the last months of the recruitment of the trial. It has to be seen. So overall, this is, in my mind, a very exciting drug because as a single agent to reach those kind of responses, about 95% disease control in follicular lymphoma, and let's say about 50% in diffuse large cell is really meaningful, and hence also now phase 2 trials will be coming our way looking at these different lymphoma subgroups, follicular lymphoma, other indolent lymphomas, as well as aggressive lymphomas.